I'm Naveed Janjua. I work at BC Center for Disease Control, and I'm senior scientist there. I lead surveillance and hepatitis programming at BC Center for Disease Control. In addition to that, I'm also clinical associate professor at University of British Columbia, and I teach epidemiology to graduate students. So hepatitis C cascade is a tool that monitor progress of patients across their illness and care journey. If you look at a single patient, so you could see or you could track a patient from acquiring infection to diagnosis, to confirmation of their infection, to treatment, and then cure. If we combine this for multiple patients at the clinic level, then we could monitor progress of entire clinic in terms of providing care to these patients. And if we combine all of the patients in a jurisdiction, let's say in Ontario or in BC at a provincial level or at a national level for Canada, it provides us a snapshot of how we are doing in terms of providing care and services to patients who are living with hepatitis C, to lead them from diagnosis to cure. So it's a tool for monitoring progress of program at a provincial or national level, and at a patient level, it could just like track progress of individual patient from diagnosis to cure. At a jurisdiction level or at a national level or provincial level, it tells you how we are doing in terms of providing care and where the gaps are. Are we letting people go or not being able to provide them services so that they are getting lost to follow up at diagnosis level or at the confirmation level, or are we not able to provide them treatment? That could be just because patients are not being able to link with care, or it could be lack of treatment. That's what we had previously, or treatment restrictions and something like that. So it tells us a story, entire illness and care journey for patients at a broader level, and then it helps us to identify these gaps and then institute strategies that could be used to bridge these gaps. In British Columbia, we see that overall we are making good progress in the initial stages of cascade, means from diagnosis to confirmation of infection to genotyping. And then it drops off at treatment, and then cure rates are decent with new treatments. And what we have started to see, treatment rates are improving with new DAAs, so that part will also improve. But of course, there are gaps in diagnosis, confirmation of infection in these stages as well. But the major gap in the cascade lies at the treatment initiation. For hepatitis C, once you cure a person, that person remains susceptible to get reinfected. So people who have ongoing risk activities, for example, people who inject drugs, once we cure them, they could get reinfected again. So that's how it's different from HIV. But that doesn't mean that we could reduce transmission by treatment. What it means is it requires much higher level of cure rate to reduce the overall number of people who could transmit to the number of people who are susceptible in the community. And that requires rapid scale up of hepatitis C treatment in population groups who are at risk of transmitting and acquiring, like for example in people who inject drugs and MSM population. So right now we are looking cascade as mainly care cascade, where we start with diagnosis and end at cure. But there are other components, especially when it comes to prevention of infection and elimination. We will need to look at prevention components as well. Prevention of primary infection and prevention of reinfection. So what does that mean? We will need to add components into the cascade such as coverage of opiate substitution therapy, coverage of needle syringe program, mental health counseling, and other interventions that could be used to prevent primary infection as well as reinfection. And then the cascade could differ in terms of a suite of interventions and suite of services for various population groups. For example, people who do not need these additional prevention component, we don't need these components of cascade for these populations, but populations where we do need them, we will need to add these additional components, whether these are overlapping cascades or whether we add these additional components to the cascade. But prevention has to be part of overall care cascade if we want to achieve hepatitis elimination. So BC is the only jurisdiction at this stage in Canada where we were able to integrate various data sets and we produce a cascade of care. This requires integration of data from lab testing with prescription and mortality. If you have like these three data sets integrated, and all provinces have these, then you could generate a cascade of care at a provincial level. And once we have provincial cascades, then these could be rolled up to a national level cascade. So provinces are moving towards that, but at this stage, it's only BC that has cascade of care. No one else has a hepatitis C cascade of care.